Good morning, everyone. Welcome to parallel session number 2, which deals with COVID therapeutics and prevention. My name is Tom Campbell. I am a professor of medicine in the Division of Infectious Diseases. I also serve as Associate Dean for Clinical Research and Chief Clinical Research Officer for UC Health. And I will be your moderator for this session. We have 2 talks. I will deliver the first talk, and Dr. Adit Gindi will deliver the second talk, and I will introduce Adit at the start of his talk. It looks like the number of participants, or the rate of participants joining us has slowed down. So we will go ahead and get started with the first talk. And for this first talk, I was asked to speak on current therapeutic and vaccine strategies in Colorado. So I will keep a Colorado focus to this talk. So just an outline of what I'll talk about. I'll give a brief snapshot of where we are at with the COVID-19 pandemic in Colorado, particularly with the spread of COVID variants. I'll then provide an overview of how we approach COVID-19 treatment, and with some emphasis on the effect of the variants on treatment approaches. And then last, we'll talk about COVID-19 vaccines, and how they are being deployed in Colorado, what we know about vaccine effectiveness against some of the variants, and also what we know about the emerging need for additional doses in immunosuppressed, and now, as we will see, with likely additional doses in healthy individuals. So I've provided here some graphs that show where we are at with COVID in both the United States and in Colorado. So the top panels are the US, bottom panels Colorado. On the left-hand side here are total cases, and on the right-hand side are deaths. And what you can see is that across the US, we are now in our 5th wave of COVID, with the first wave beginning in March and April of 2020, and we're over here now with this wave that is really surging in the late summer. And you can see that what has happened in Colorado largely parallels what's happened nationally, with a couple of slight differences right now, which is this most current wave of infections seems to be somewhat less in Colorado. And although deaths are starting to tick up nationally, we're not yet seeing that here in Colorado. A lot of this is happening with different things that are going on. So number one, since late December, early January, we have had a mass vaccination program. Also, since beginning of the year, we've also had the spread of variants. These first 3 waves were largely caused by fairly similar strains of COVID-19, similar to the Wuhan strain where COVID started. But since January, as Dr. Maravich showed across the US, we first had the spread of the Alpha variant, which caused this wave in late winter, early spring, and now we're seeing the spread of the Delta variant. And it's important also to realize that at least since the late spring, we have had diminished public health interventions, so diminished mask wearing, diminished social distancing measures, although we are starting to see in some states, in some areas, a return to some of those public health interventions. So let's just look at what is going on with the variants here in Colorado. This is monitored by the Colorado Department of Public Health and Environment. They've started doing this at the end of 2020. And as I described before, beginning in late spring, we saw this wave of the Alpha variant spread throughout the state. And then that was rapidly overtaken by the Delta variant, which first started appearing in the state in mid-April. At the present time, Delta makes up almost 100% of all the new infections in the state. Delta is important because it has increased infectiousness compared to the previous variant, the Alpha variant. And the rate of household transmission of Delta is 64% greater compared to Alpha. If you compare it to the variants prior to Alpha, it's almost twice as infectious. There's also evidence that Delta has increased virulence compared to Alpha. The risk of hospitalization is increased 85% compared to Alpha. And there, as I'll show you, there's evidence for decreased laboratory susceptibility to some of our monoclonal antibodies and decreased effectiveness of vaccines, as I will show you. So a lot of what we do in therapeutics for COVID, as well as for vaccines, is focused on the virus spike protein. So this is the protein on the surface of the virion that engages the ACE2 receptor on the cell surface and allows infection of cells. And these variants are of concern because of the mutations that they have in the receptor binding domain of the spike protein. So the spaghetti here is the ACE2 receptor, and the more dense structure here is the receptor binding domain. And here are some of the key mutations that affect the interaction of the receptor binding domain with ACE2. The original strain that we dealt with is often referred to as D614G. That's because as it spread from China through Europe, it acquired this mutation, likely in Europe. And then alpha, beta, gamma, and now delta have emerged, and they all have these slightly different receptor binding domain mutations. The overall effect of these mutations is to increase the affinity for binding to ACE2. There is increased respiratory viral shedding that is believed to be a large part of why there is increased transmissibility of both the alpha and the delta variant. And these mutations lead to decreased efficacy of neutralizing antibodies, and that includes neutralizing antibodies that might be generated in response to natural infection, as well as the recombinant monoclonal anti-spike antibodies and the antibodies that are induced by COVID vaccines. So these tables just summarize some of the effects of these mutations on monoclonal antibodies. Our next speaker, Dr. Gindi, is going to go into a lot of detail about monoclonal antibodies. I'll just point out that the single monoclonal antibody, bamlanivimab, that was widely used during the December through January wave, its efficacy is greatly reduced by all of these variants. The combination of bamlanivimab and atazivimab also has significant reductions. The combination of casaviramab and imdivimab that's produced by Regeneron, fortunately, is not affected by the mutations in the current variants. And this is the main combination of monoclonals that we use for treating patients here in Colorado. This is a cartoon of what we see in patients who present with COVID and what happens over time. And the important things are that after infection during the early period of COVID, it's a period of viral replication. There's a lot of virus shedding in the upper respiratory tract and high potential for transmission to others. With time, as the host immune responses start to kick in, the virus shedding decreases, and so does transmissibility. But in some individuals, those that are at high risk for developing severe and critical COVID illness, there's a very exuberant inflammatory response that we believe is responsible for a lot of the clinical presentations in severe and critical COVID, and is a target for our treatment of those individuals. So I'll just go through our treatment algorithm that we use at UC Health. This is based on the guidance that's provided by the Department of Health and Human Services COVID treatment recommendations. So we do have preventive measures that can be used. So for people who are at high risk for severe or critical COVID, if they have a significant exposure in the community or at home, we can use monoclonal antibodies to prevent subsequent illness. So that's what we would call post-exposure prophylaxis. For people who are infected and develop symptoms of COVID in the outpatient setting, the monoclonal antibodies are our main course of treatment for people who are at high risk for progressing to severe or critical illness. It's important that these antibodies be given early on, within 10 days of the onset of symptoms. As I showed you in that previous cartoon, it's that early period where there's virus replication and virus shedding, and that's the period where the virus-targeted agents are the most beneficial. And then for outpatients who were recently in the hospital, or for those that were seen in the emergency room and had severe COVID but were not admitted, we do use the corticosteroid dexamethasone in those settings. For people who are admitted to the hospital, our treatment approaches depend a bit on what the severity of the illness is. Those that are hospitalized but don't require supplemental oxygen, we don't usually give any specific antiviral or immunomodulatory therapy. For those that require low-level supplemental oxygen, we use the antiviral remdesivir. It's a inhibitor of the viral RNA polymerase, plus the corticosteroid dexamethasone. For those that have more higher level oxygen requirements, we again use dexamethasone, consider remdesivir. And for those who may be progressing rapidly, it's been shown that the IL-6 receptor antagonist tocilizumab can provide benefit. For those with critical COVID who require invasive mechanical ventilation or extracorporeal membrane oxygenation, ECMO, we use dexamethasone, and we consider the possibility of tocilizumab. So what you can see is that for severe and critical COVID, our mainstays of treatment at this time are anti-inflammatory approaches. So let's turn now to COVID vaccines. As Dr. Marovich indicated, there have been 6 candidate vaccines in phase 3 clinical trials in the US, and those came to us out of 110 vaccines that are in various clinical trials around the world. and as well as 284 vaccine candidates that are in various stages of development around the world. And I've summarized here in this table where we are at with these 6 vaccines. Pfizer BioNTech vaccine, which is a mRNA-based vaccine, has completed the primary efficacy analysis for its phase 3 trial, although the phase 3 trial is still ongoing. As we know, we have an emergency use authorization from the FDA since 2020. Similar for Moderna, since December 2020, we've had emergency use authorization. Both the mRNA vaccines in their initial efficacy analysis had very high, very similar efficacy. The adenovirus-based vaccines, only the Johnson & Johnson / Janssen vaccine has EUA in the US, and the primary efficacy for both of these vaccines is slightly lower than for the mRNA-based vaccines. I think this table really highlights that the mRNA and vector technology really enabled us to get vaccines into use quickly. If we were still dependent upon the protein subunit technology, such as the Novavax and Sanofi vaccines, we would not yet have an emergency use authorization. Novavax has completed their phase 3 safety assessment and have reported about 90% efficacy in their clinical trial. Sanofi, as Dr. Maravich mentioned, just started their phase 3 trial a couple months ago. So the important thing about the vaccines is that they induce antibodies, neutralizing antibodies targeted at the receptor binding domain of the S1 subunit of spike. And this is affected by those mutations that we saw that exist in the receptor binding domain in the emerging variants. And this slide just shows the effects of the alpha, the beta, gamma variants on the receptor. The effect of those mutations on antibody neutralization with antibodies that are induced by vaccination. What I've summarized in this slide is what we are seeing in the real world. So this is effectiveness. I've used the term efficacy to describe how we measure vaccine effects in clinical trials, and effectiveness to describe how we measure vaccine effects in real world or community settings. So for the 5 vaccines that we use in the US that we have data on, I've indicated here in this table what their effectiveness is for the D614G variant, the alpha, the beta, and the delta variants. And what you can see is effectiveness for Moderna and Pfizer for D614G are very good. It's very similar to what was measured for efficacy in the clinical trials. Likewise, with the alpha variant, also very good levels of effectiveness. With beta, which has not been a big problem in the US, although was a big problem in Southern Africa earlier this year, the Pfizer vaccine does have less effectiveness. And we also see drop-off in effectiveness for both Moderna and Pfizer with Delta. And importantly, this is a measure that uses any infection. So for preventing any infection, Moderna is somewhere in the 76 to 85% effectiveness range, Pfizer in the 39 to 88% range. So there's quite a range of effectiveness reported in different studies. What's also important is how well the vaccines protect against severe COVID. So this would be COVID that lands someone in the hospital. You can see for alpha, very high levels for the mRNA vaccines, and for beta, But for Delta, again, effectiveness for hospitalization drops off, although it's still high and still good, just not as quite as good as it was before. So this just summarizes where we are at with vaccination in Colorado. So far, 6.7 million doses have been administered in our state. And that has resulted into that about 55% of the entire population is now fully vaccinated, and 66% of the 18 and over population is fully vaccinated. We've mainly delivered the Pfizer and Moderna vaccines. The Pfizer vaccine has accounted for 56% of doses in Colorado, Moderna 40%. The Janssen adenovirus vaccine, only 4%. We've done a pretty good job immunizing our older population. This just shows the percentage of people 65 and over who have received at least one dose of vaccine. Statewide, the average is right at 90%, and with many counties in the plus 90% range. And that has affected hospitalizations in our state. So this graph here shows hospitalizations by age group across Colorado for the entire pandemic. And you can see that going back to the waves that hit us in March and April of 2020 and in November, December of 2020, that those 60 and over accounted for the majority of hospitalizations. Of course, we had vaccinations beginning for the older age groups in January, and by April, those 60 and over accounted for only 36% of hospitalizations. Unfortunately, vaccine uptake has been less in younger groups, and they now count for an increasing percentage of our hospitalizations. One of the questions that was raised in Dr. Marovich's talk was about whether or not antibody levels correlate with protection. And this is just the data from a preprint that Dr. Marovich mentioned by Peter Gilbert from the Fred Hutch. And I would emphasize here, so if you look at this, these forest plots here on the left, this is the forest plot for binding total antibodies. This is total IgG against spike versus neutralizing antibody in a pseudovirus assay. And what you can see is that there is a correlation in these different groups of people for antibody level and protection against COVID illness. But the correlation is much stronger with much lower hazard ratios when neutralizing antibody is measured. In these graphs here, the shaded area just shows the distribution of pseudovirus neutralizing antibody titers and the probability of getting COVID by day 100 of the trial. So these data are all from the Moderna vaccine phase 3 trial. And you can see that once you get in the 100 to 1,000 range, the probability of infection drops off quite well. And then this looks conversely at vaccine efficacy against COVID illness by neutralizing antibody titer. And again, when you get to the 100 to 1,000 titer, when you get to the titers of 100 to 1,000, there is greater than 90% vaccine efficacy. An important caveat to these data are that these are all data from the randomized placebo-controlled portion of the Moderna trial, which ended in January. And so all of these data are based on the D614G virus, and we don't know what the correlation is between neutralizing antibody levels for the Delta variant. This slide summarizes the vaccine efficacy effectiveness in immunocompromised individuals. And what I would highlight here is that when you look at all these different potential risk factors, that the one that stands out the most is being immunocompromised. And these are data that were generated by a multi-site collaboration. And I'll point out that 2 of the first 4 authors on this paper, Dr. Gindi, our next speaker, Dr. Doohan, are from University of Colorado. So these data are very important because they really emphasize that vaccine effectiveness really drops off in people who are immunocompromised from organ transplantation, from cancer treatment, et cetera. There's also data that the efficacy of the Pfizer vaccine is waning over time. And what I would point out here in this table is vaccine efficacy measured in the Pfizer clinical trial at different time points, in that by 4 months after the second dose, that efficacy has dropped off to only 84%. And so that has led to some of the data contributing to our recommendations, or the emerging recommendations for booster vaccines for most Americans, perhaps beginning by the end of September. So I will stop my presentation there, and we have a few minutes for questions. If anyone has any, you can unmute your microphone and ask me directly. So just looking at the chat, someone noted that the surges in cases and deaths in Colorado preceded those in the whole US. Yes, to some extent that's true, particularly for the wave in December. Then are the monoclonal antibodies available for use in children, specifically children less than 12? I do not believe so. Perhaps Adit can answer that in his question. I think they are available for adolescents, but not for children less than 12. Adit did answer that in the chat. Thank you, Adit.
Tom, can you hear me?
Yeah, hi, Tom.
Hi, Tom. Great presentation. Really appreciate it. Enjoyed it. Could you just make a quick comment on cancer patients and giving a third shot? Cancer patients range from those with leukemia and lymphoma at one end, and maybe prostate cancer patients at the other end. That immunocompromised category, at least to me, I think I've heard other people talking about trying to understand that better.
Yeah, so the FDA and CDC has not given strict criteria for what constitutes immunocompromised state in cancer, other than to say that these should be patients who are on or recently received treatments that would suppress their immune system. So someone who has skin cancer and just had a Mohs surgery, obviously that's not someone who qualifies, but certainly patients who are getting immunosuppressive chemotherapies or biological agents would qualify.
Thanks, Tom. That's helpful.
Other questions?
Tom?
Hi.
Hi. Is the drop-off in efficacy of the Pfizer vaccine over time related to all infections, or is it still protective against hospitalization and death at a similar rate? Because there seems to be that discrepancy.
Yeah, so that that data that I showed you from their phase 3 trial was for any symptomatic infection.
Right.
And so that was their primary endpoint. So yes, it still gives good high-level protection against infection. Again, the caveat for those data are that those are with the D614G virus.
Right.
But we have seen drop off in effectiveness with the Delta variant. The clinical trials won't be able to measure efficacy against the Delta variant because they all became open label and everybody got immunized in January.
Right, right. Okay, thanks.
Question in the chat is, are people 70 and above recommended for the third dose or not yet? Not yet. We expect that guidance will be coming about that in the next several weeks, pending FDA and AICP review of the data. All right. Well, thank you very much.
I had a question. Excuse me,
sure.
I raised my hand. I'm sorry.
Oh, I'm sorry. I didn't see that.
Anyways, I just everything you talked about, it was really good and great to get the facts and the status of where we're at. I'd like to, if you could speculate a little bit on the future, because what I did not hear, you know, normal strategies we have is we develop therapeutics, and now it seems like the vaccine is kind of taking over, and that's what everybody is focusing on. And it would just seem to me that a better strategy would be to have, you know, a combined thing. And I don't seem to hear very often about therapeutic approaches, or perhaps I missed it. And you did talk about which agents were used, but they were clearly not specified for that. And so it's sort of random that they happen to have that effect.
Yeah, so that's a good question. So yes, it is true that some things that have been used are things that were developed for other purposes and happen to have an effect. The exception to that is the monoclonal antibodies, which were designed specifically to target the virus spike protein. And there are other agents in early stage clinical trials that inhibit other steps of the virus replication, including some orally bioavailable agents. Those are still in fairly, you know, phase 1, phase 2 type clinical trials. I've not yet seen phase 3 data.
I mean, I'm sorry, I did not introduce myself. I'm Debbie Kranz from Colorado State. I'm a chemist, biologist sort of mix. Anyways, it just seemed like it would be nice to get a sort of a view of some of this, because, you know, if you're thinking about what to possibly go and what to test, I mean, good idea is a good idea. It doesn't matter if it comes from somebody that actually has the background with that. And thinking about these proteins and how we can inhibit it would be seemed like a good approach to take. Anyway.
Yes, and that approach is being taken. So it's not just vaccines, although I think it's the vaccines that are going to change the course of the pandemic, not treatments.
Yeah, these other things are more long-term, but we have to think short-term and long-term, right? So yeah. Thank you very much for the presentation. It was great.
You're very welcome. Thank you for the question. So are there any in the chat, are there any studies on the efficacy of vaccines and or therapeutics in autoimmune patients? And are there studies following their immune response to vaccines? So autoimmune disease itself, it was not an exclusion criteria for the vaccine studies, although autoimmune disease requiring immunosuppression would be expected to affect vaccine efficacy. There's no evidence that having an autoimmune disease increases the risk of side effects from the vaccine.